with lung disease. And we've got a great panel of experts to speak to that topic. And we're going to cover a whole host of different areas this evening. And we really want this to be an interactive session. So after our speakers have each spoken for approximately 10 minutes, we'll have a little break, and we'd like you to take some time to write down questions and comments, and then we'll reconvene and we'll pose those questions to our speakers. So hopefully it'll be a really nice interactive session. So just before we start, a little bit on COPD, and I am by no means an expert in this area at all. I'm an exercise physiologist, specifically interested in cardiovascular health, but our experts this evening are very much COPD experts. But for those of you who don't know, chronic obstructive pulmonary disease is one of the most common chronic diseases globally, and it's characterized by progressive and generally irreversible loss of lung function. Worldwide, and I didn't know this until I was handed this information earlier on, the prevalence of COPD has increased by 44% between 1990 and 2005. If you then take it to Canada, approximately 17% of the adult population have COPD. And over the next 15 years, that number is expected to double. So this is a serious issue. It's also very interesting that the rate of this disease is rising rapidly in women and has become one of the leading causes of mortality in women worldwide. In fact, COPD kills more women in the world today than breast and lung cancer combined. Further, the number of cases of COPD is reported to be growing nearly 3 times faster in women than in men every year. I'm guessing that's probably something we'll pick up on in our discussions this evening. COPD has significant impacts on the lives of Canadians in terms of overall health, mental health, and limitations to mobility, activities of daily living, work and volunteer participation, and of course social and recreational activities. Although COPD is a chronic disease that is often preventable and indeed treatable, and I'm sure we'll come to some of those areas this evening. Regardless of the disease severity, individuals with COPD identify relief of breathlessness as their top healthcare priority. And indeed, it's a top priority for researchers in this area. So we're here this evening to address many of these issues and to discuss these widely. And we've got a great panel of experts to help us along that journey over the next hour or two. Now I'm going to introduce each of the speakers so you know who is going to be speaking over the next hour. Okay, so our first speaker will be Dr. Douglas Rolf, probably known to many of you in the room this evening. Doug is originally from Edmonton, did his undergraduate in genetics, followed by an MD at the University of Alberta in the internal medicine in Ottawa, respirology back in Edmonton, and critical care in Calgary. Has been in medical practice here in Kelowna since October 1991. His current practice involves a focus on respirology, seeing patients in his office, providing hospital care, and some clinical research as well as some involvement in teaching. After Doug, we'll have Ms. Shelly Rowe, who is a Kelowna resident who's living with COPD and will share some of her experiences with us this evening. After Shelly, Dr. Joshua Brinkerhoff, who's an assistant professor in the School of Engineering up at UBC, will be speaking to us. And Dr. Brinkerhoff grew up in Kelowna, and he's very excited and pleased to be back here as an assistant professor. He's in the School of Engineering. His research group conducts very large-scale computer simulations to understand the behavior of fluid flows. So what we've got here is a real difference in expertise in the panel. And although his primary focus on aerospace, energy, and natural gas industry, he also investigates how airway diseases such as emphysema impact airflow through the human lungs. So he'll bring a really different view on this issue. After Joshua, we've got one of my colleagues from the School of Health and Exercise Science, Dr. Neil Eves, who's an associate professor in respiratory and cardiovascular physiology. He's also the co-director of the Center for Heart, Lung, and Vascular Health at UBC. And his current research focuses on how the pulmonary and cardiovascular systems interact and how these interactions mediate adverse symptoms, exercise intolerance, and the accelerated progression of cardiovascular disease that occurs in patients with chronic respiratory conditions. Neil's program is also exploring the role of novel exercise therapies, specifically tailored to alter and reverse some of the adverse changes that occur in respiratory conditions such as COPD lung cancer, and idiopathic pulmonary fibrosis. Our final speaker after Neil is Dr. Pat Camp. Pat is an associate professor in the Department of Physical Therapy at UBC in Vancouver and a researcher at the UBC Centre for Heart-Lung Innovation at St. Paul's Hospital in downtown Vancouver. In 1997, she created the St. Paul's Hospital Pulmonary Rehabilitation Program and has been involved in clinical care, research and policy ever since. Her research interests focus on tele-rehabilitation, exercise programs for people who are in hospitals with chronic lung disease, and indigenous lung health. So each of our speakers this evening will have about 10 minutes. We'll then have that little break. If you can make any notes and any questions along the way. Often I find that I forget if I don't write it down, so make sure if a question or thought comes to your mind, write it down, and then we'll have an opportunity to share all those questions and comments afterwards. So welcome once again, and with that I'm going to pass on to our first speaker, Dr. Douglas Rolf.
Oh, thank you. I'm very honored to be asked to be involved in this. The panel here I think is quite expert and quite excellent, and certainly has huge impact in respiratory care and respiratory lung issues over time. As mentioned, COPD is very important. It's very prevalent, and it's actually one of the #1 admissions and problems and readmission reasons for people to be admitted to hospital. And if you have obstructive lung disease and you're admitted to hospital, your chances of surviving a year later is about 21% less than, well, basically mortality is about 21–22%, which is higher than acute heart attack. And that's because there's significant other comorbid conditions that are ongoing, and in men and women. What I thought I would do is just basically talk to you first and explain a little bit about what obstructive lung disease is. To the 10-minute mark, I'll get the cutoff, and hopefully I won't go that far. But I want you to first off just talk about a few things. One is emphysema. One is chronic bronchitis, and I'm going to add asthma to the list as well. And emphysema, the first thing I'm going to have you do is I'm going to have you think about a sponge. And the sponge has got holes in it. And sometimes there's larger than normal holes, and sometimes there's huge holes. If you say that sponge is now a lung, any hole that's larger than normal up to and including those huge holes would be emphysema. And you say, okay, so it makes it a bit floppy. Well, if you all take a deep breath for me for a minute, and then let it all out. What's happened there is you've used your muscles to lift the chest wall up, and you've expanded those lungs, and when you let the air out, it's the elasticity in the lungs that are bringing that down, and where the balance point for the lungs to collapse and the expansion point for those ribs to go out, at that point, that's sort of the zero balance here. You've got something called a functional residual capacity left. So to let the air out, you need to have the elasticity in the lungs, and of course with the emphysema, you lose some of that. The second thing is if you take a balloon and you go let it out. Well, if you think of the little tiny airways in the lung, it's like that balloon neck, but it doesn't have any support. And so with emphysema, you lose that support, and so the air doesn't get out of the lung as easily. Whether that be one little tiny area with a huge bleb, or whether that be a whole bunch of little areas of damage and smaller amounts of lung, the airflow obstruction is still there. And so when you take that deep breath with obstructive lung disease, instead of going, you're going, and you're having the obstruction and you have the difficulty getting it out. And so with exercise and activity, basically you're going, and now you can't get a breath because basically you can't get a breath in because your lungs are full. And it's not the issue getting the breath in, it's actually you can't get rid of the air. Now that's what will happen with the emphysema. With the chronic bronchitis, in the most simplified terms, there's an obstruction part and there's also a non-obstructive part. The definition of chronic bronchitis is someone who's produced a little bit of mucus for most days of a month for at least 3 consecutive months in a row in a year for at least 2 consecutive years. 15 years ago you had to do it for 3 years, but 2 years is enough. And then the bottom line is you're making more mucus than normal. Mucus, important. It's part of our whole body's defense system. That's why you have mucous membranes. It's what picks up bacteria, dust, debris, and with the lung, when you take a breath in, normally the airway gets expanded. You stop inhaling, the airway comes down. You exhale or let more air out, the airway gets even smaller. Same volume of air, smaller space, higher velocity, the secretions go and out. That's the ideal. And with the chronic bronchitis, you're making more mucus than normal. Now, everybody in this room makes mucus. If you don't, we'd have significant other problems. You'd be making mucus for other reasons. So if you don't have mucus, you're probably going to not be here. And if you take cystic fibrosis, I know I'm diverging a little bit, but with cystic fibrosis, there's a problem where you don't have the proper chloride amount, which causes the mucus not to function properly, which causes problems with infections and all sorts of other issues. So clearing the mucus is extremely important. So with the chronic bronchitis, you're making more mucus, and there's the obstructive component. There's also some small areas of inflammation and other damage that occurs. So the bottom line is either way with the emphysema or the chronic bronchitis, you've got an airflow issue. If you get inflammation, more mucus, those airways get even smaller, more problems getting that air out, and you're more likely to end up with that and can't get the breath because you're full, your lungs are at full capacity. And so you have to stop and rest. Now, of course, women, their lungs are smaller, and because they're smaller, the airways are a little bit more collapsible. You run into all sorts of other issues related to the lung disease. If there's malnutrition issues, or you have the addition of cigarette smoke, you end up with more lung damage. And we find, sadly, because of some anatomy and other physiology, that in things like bulimia, you have more emphysema because of the damage done to the lungs because of the weight loss and loss of protein. If you have issues as far as asthma, the asthma in the most simple, straightforward scenario is a situation where the airways have more inflammation, more irritability than normal. The classic definition is there's times where the airflows are absolutely normal and the airways are normal, and other times where there's inflammation and reactivity. If I take 100 people at random and put them in this room and I put dense smoke in, every single person, every single one of those people will have a problem, just as if, and basically have issues with either coughing or wheezing or getting out of breath. If it's a little bit of smoke, then 15% of those people, or 15 of those 100 people, would have problems just as if it was the dense smoke. And when you look at that subgroup, some are within 2 to 6 weeks of a cold, some are within basically 4 months of an infection of the airway or an acute bronchitis, and then the rest will have asthma. Now, the important part about the reactivity is when you get exposed to something, whether it's an allergen or whether it's an infection or an irritant, basically there's signals and messengers that are released. They stimulate the airway to tighten up. They stimulate a little bit of mucus, and that might last 15 to 20 minutes, and then it settles down. But over the next 2 hours to 2 days after that, you get inflammation developing in the airway. And so if I rub my hand, or I can't do that because I've got the microphone in my hand, but if I rub my hand and keep rubbing, eventually that tissue gets hot, sore, and swollen. Well, that inflammation develops in the airway. Well, the outside of the airway doesn't get any bigger, the inside gets smaller. And so some people will end up with a delayed attack or delayed reaction because of the inflammation. And untreated, you run into issues. Okay, I have the 2-minute warning. So if you take a nice little circle, you make a circle and you write emphysema, you take another little circle and you overlap it, you've got chronic bronchitis, and you take another little circle and you overlap the other two, now you have asthma. So you've got some people with chronic bronchitis, some people with asthma, some people with both. You've got some people with emphysema, some people with chronic bronchitis, some with both. Some with emphysema, some with asthma, some with both, and of course there's some people in the middle that have all the above. So all of these things are in there affecting our ability to breathe and function, and unfortunately, as indicated, it is going up and increasing in time, and there's a lot of things that will impact that. And I think with that, I will turn this back to our host.
Thank you very much, Doug. So our next speaker is Ms. Shelly Rowe. Of course.
This definitely was not on my bucket list.
We won't give it.
Right. My first incident of knowing I had a problem was Thanksgiving of 2013. Ambulance ended up taking me to the hospital, where I spent 5 nights on oxygen. and was diagnosed with COPD. At that time, my 3 best friends became Spiriva, Flovent, and Servent. They were my lifesavers. Life went along pretty good for me for the next 4 years. I had my odd bout of bronchitis, but I continued working. I worked at a spa, and I eventually started to find that the different scents and perfumes that people wore really started to irritate me. I got to the point where some days cleaning the petty tubs was a breeze, and vacuuming as the night was over was a breeze. Other nights, it took everything in me to do that same task that just had always come so naturally to me. From there, I went and worked at a pro shop at a little golf course, a 9-hole golf course. And thank goodness I was the one in charge of scheduling so that I could schedule myself in the dead of winter to work the late shift. So I wasn't in this little shop with no air conditioning at the heat of the day. And I could be the ones driving the golf carts up to put them away in the shed, rather than the one in the morning having to hoof up what was a small little hill, but to me some days was like climbing Knox Mountain. And so I would schedule myself as days went on to work the night shift where it was cooler and I didn't have to exert myself much. I didn't want to admit that something serious was probably going on with me. I just took it as age and smoking. I was told when I ended up in the emergency in 203, smoking is your worst enemy. And subconsciously, I knew it was, but thought, oh, I know better, and things will get better. Well, the spring, March of 2017, we'd had some really horrific incidents in the family with 2 children. One of them ended up stabbed 17 times, did survive the stabbing. Another one ended up in the psychiatric ward here. And I was attributing my weight loss and my anxiety to trouble at home, not realizing how sick I was also getting. My husband took me to the doctor on a Thursday, and I even fooled the family doctor. He knew our family history, and he knew I had suffered from panic attacks before, so he just assumed, you're probably right. You just need to get yourself some counseling, calm yourself down, and home we went. Before we left the doctor's office, so unbeknownst to me, my husband said to the family doctor, she's putting an act on for you. This is not what's happening at home. And he said, okay, we'll see you on Monday then. Let's see what happens then. We went home. I don't even remember ever going to that doctor's appointment. In hindsight, my husband phoned the ambulance on a Friday night and said, like, we've got trouble here, and explained what was going on. And they said, well, if it's anxiety, let's just leave it a day. We'll put you over to the nurses on 811 or something to talk to. So they did, and I guess the nurse talked to me. I don't remember. But I told her, no, it was panic and anxiety, and I'd be just fine. The next day, being a Saturday, my husband thought, no, this is enough. Like, I can't even carry this woman off the couch to go to the washroom, never mind eat. So he convinced 911, no, this is serious. Let's get her to the hospital. So they did, and I guess they tried to stabilize me in emergency. I had 39 blood tests done for them to try and figure out what was going on with me. And it was discovered that I had pneumonia, and I had sepsis, and I was in severe liver failure. I guess my CO2 levels, my carbon dioxide, was just off the map. They tried a CPAP on me for a day or so to see if that would help my breathing at all. It did absolutely nothing. I guess my body, my organs were just so weak that they almost said to my husband, you know, we're not really sure, you know, we wish you luck. kind of thing. They ended up putting a ventilator in me in ICU, where I spent 12 days. The only thing I remember about those 12 days is, I guess when I would come to, I would see staff at what looked like an upright glass freezer opening and closing it. And I thought, what the hell are these people doing eating Dairy Queen ice cream cakes when I'm lying here needing help? Unbeknownst to me, I found out later that this was actually where the medications were kept. But for me, I just couldn't get it. And I couldn't speak to say, like, hey, what about me? Anyhow, I eventually came back to my senses 12 days later. I guess they took the ventilator out. They weren't sure whether I was going to be able to breathe on my own. They said to my husband, you know, our next step, if this doesn't work, is to do a tracheotomy. So anyhow, by the grace of God, I didn't need that. I was released from the hospital after 16 days, where I came home with a walker and a stool for the shower, and I was skin and bones at 5'9" and about 129 pounds. If that, I needed help to get off the toilet, to get on the toilet. Anyway, then was the time when I thought, you need to fight for your life. So I went on the internet, and thank goodness for Google, because Google knew Todd Gale's name. And it said Dorchester Respiratory Therapy. I thought, well, I've got a phone. So I phoned, and he invited me to go to the Dorchester monthly meeting, the next meeting, which was in April. And I am an introvert, total introvert. But the survivor in me said, you've got to go. So I got myself and got my walker in the car and thought, off to the Dorchester I'll go, not knowing a person. Todd greeted me there. He introduced me to Julian Kushner, who became my guru. It is because of him I am here today. He talked me into going to rehab 1 day a week. Would I sign a contract to go 1 day a week to rehab? And I thought, well, sure, I could do that. And about a month later, he said, you really need to commit to 2 days a week. And I thought, oh, God, okay, I'll do that. It was just for 6 months, he said. So I thought, okay, I'll do that. And at the end of that, he came to me in the middle of July and said, you know, if you ever want to quit smoking, I can help you with that. I won't pressure you about it, but I can help you with that. So September 6th, I have been smoke-free since September 2017, so we're going on 2 years now. I've never looked back. I'm heavier than I've been in years. I go to the gym now, though, normally 4 days a week. I go to the Dorchester rehab that I couldn't live without. They are a great support system, and they're only 2 hours the second Wednesday of each month. And it's just been life-saving. I cannot say enough about how good respiratory rehabilitation is for people like me. They're a great support system because with COPD comes breathlessness, which brings anxiety. It's like the chicken and the egg. You're not sure which comes first and what starts what. And there was one day at respiratory rehab where my anxiety was so bad that I said to Julian, I'm out of here. I'm gone. And he said, no, just sit, follow me into the gym. I'll check on you. He's working with a client that had oxygen. And I'm literally calling, Julian, Julian. So he finished with this lady, came over to me, checked my pulse, said, you're okay. It's just anxiety. Just take it slow. And I did. And I am healthier and happier now than I have been in years. And it is. It's all thanks to Todd and Julian and Renee, Parkinson Rec Center for giving a subsidized rate to people on disability who don't make a lot of money, that make it available for me to go and participate. And I hate to see Interior Health take any funds away from them because it is a lifesaver for us. Anyhow, thank you.
Shelley, thank you so much for that wonderful insight.
I should have said too, I couldn't do it either. Nobody can without a good family doctor, a good pulmonary doctor,
No. Thank you so much, and a great advert for rehabilitation there, for sure. Our next speaker is Dr. Joshua Brinkerhoff.
Thank you. So my perspective, again, will be a little bit different because I'm an engineer. Why is an engineer here with all of these health professionals? And the answer is somewhat serendipitous. I started my research career at UBC Okanagan in 2014, and shortly afterwards was approached by one of the materials professors, also another engineer, who was working with COPD specialists in Vancouver, Dr. David Hogg. And they had a technology where they could take a 3D X-ray, very, very microscopic portions of the lung, and see what the structure is and be able to visualize it in 3 dimensions. And they had that ability to understand the shape of those little sacs that are filled with air that Dr. Rolf was talking about that are affected by emphysema. And they understood what happens with emphysema. These sacs become bigger, the airways become the air regions become larger, they lose their elasticity, and they understood the anatomy and the pathology. But they didn't understand, well, what happens at the very beginning of the disease? What happens when the disease progresses? We understand that there's these mechanisms that the airway space gets larger, and we know that the tissue becomes less elastic, and we know that there's less flow in and out. But which happens first? And how do they interact? And then the result is we know there's less oxygen that gets transported to the tissue, so there's less oxygen being exchanged. And we know that there's more resistance in the lung. And we know that the air has a tendency to swirl around when the spaces become bigger, but we don't know which causes which effect. And we can't understand that. And so that's, I think, where computer simulations come in, because computers are not stuck with the real world. We can change things, and we can separate causes and effects to understand what's going on. And so what we did is we took a mathematical model, simplified geometry of these little air sacs. They're called alveoli. And if you want to know what the mathematical model looked like, it was a mathematical representation of them. It looks like a little blue, or maybe a blackberry, a large bulb with a bunch of little bulbs around it. And we had one of those, and then we had a bifurcation, and then one more after each branch. And that was our computer model. And we would build a mesh inside that model where we would solve the governing equations that govern the fluid motion in that model. And then we applied boundary conditions, and we allowed the alveoli to go bigger and smaller as they would normally during breathing. We had flow rates in and out that were representative of the healthy breathing and diseased breathing at various stages. And then we were able to do what the body can't do. We were able to separate things. So we would say, imagine what happens if this emphysematous pulmonary acinis is affected only by the loss of tissue, but the flow rates in and out is just as if a healthy person. Or the other way around, the flow rates in and out are affected like someone suffering from emphysema very severely, but they haven't lost any of their tissue. And we were able to make these changes independently of one another to understand what impact those had. And then we were able to simulate these geometries using computer simulations. We had a lot of different cases. We were able to run different analyses to understand what the different causes and effects were and to split things apart. And the work was done primarily by my graduate student, who's now moved on to doing a PhD. But the results that we came about were quite interesting, and I'll just summarize them. One of the things that we found was the loss of the septa tissue, so the tissue between these little sacs, if you like, between the little bulbs on the blackberry. That loss of tissue didn't seem to have much of an impact on the transport of oxygen within the sac, so from the airway towards the alveolar walls. the loss of the tissue didn't seem to have any impact on the oxygen transport. Whether the tissue was intact or whether it was diseased didn't modify the transport of oxygen all that much. The loss of the tissue did have a significant impact on the hydraulic losses. That means the difficulty of getting the air out of the lung. When there was less tissue, it was easier to get the air out. And that was somewhat paradoxical because we know that emphysema is associated with making it more difficult. And in fact, the answer is that because there's less elasticity, like Dr. Rolf said, you're breathing into a balloon versus breathing into a plastic bag. And with the plastic bag, there's nothing squeezing that air out again. And so that was helpful. The other thing that we saw was the cause that primarily affected the oxygen transport in and out of the lung, in and out of the alveolar sacs, was the flow rates. And so that was helpful for us to understand. And the other factor that we saw that wasn't quite understood was when you have a loss of these tissue, interalveolar tissue, or the septa as they're called, that's where the gas exchange takes place. But not only does that affect the gas exchange in and out of the lung, but it also causes the air to flow in a kind of circulatory pattern. When the septa are intact and when the alveolar structure is healthy, the air flows nicely in and then out again. But when there's a disease, the air has a tendency to swirl around, and you get these recirculatory patterns. And what results with the recirculation is that you have particulates, aerosols, things that you're breathing in, either medication or cigarette smoke or other things. It's in that recirculating flow, and so it's harder to get it out. And once it's in, it has a tendency to stay in and become deposited. And so what we thought, seeing that the removal of tissue due to the emphysema disease, the removal of tissue promotes this recirculation. The recirculation promotes more deposition, and the deposition likely triggers an inflammation response. We saw a sort of positive feedback loop where the beginning of the progression of emphysema would tend to promote its increased or enhanced progression. And that was helpful to understand. And so our simulations were able to give some clarity at the very, very beginning stages of the disease as to what causes what effect, and be able to split things, which would be not possible to do in real life. And the other comment that I should make is this was also motivated by the fact that it occurs so deeply in the lungs that it couldn't be imaged using in vivo, in a human patient, using CT scans. It would be too deep in the lungs, and the CT power would be too high, it would be not safe. And that was another reason what motivated us to do computer simulations. Now what's following on from this work is we want to understand with our computer simulations, what if we added particles into our simulated flow? Then we can see how much particles are being deposited and how much are coming back out. And that would allow for us to get better insights into aerosol delivery of drugs and other treatment approaches. Thank you.
Thanks, Joshua. Very insightful. Now I'm going to move on to next speaker is Dr. Neil Eves.
Thank you, Rob. Thank you, Joan, for inviting me. And it's nice to see so many people here and so many faces, a few faces that I know at least, which is very nice to see. So my sort of journey into research in the respiratory world it sort of started off very differently. I'm an exercise physiologist, interested in exercise. And I came to Canada about 20 years ago. I came to the U of A to do work with athletic populations, and I was interested how the lungs limited athletic performance and what we could do from an exercise perspective to make athletes work better. And I met a gentleman there called Dr. Dick Jones, who I believe actually trained Dr. Doug Rolf to a certain extent as well. So he's been around a long, long time. He now makes wine in Naramata, so he's sort of one of our locals now. But he sort of suggested to me that some of the stuff we knew might be very, very good, not in athletes, but in respiratory populations, and maybe we could apply some of this to people who have respiratory conditions. So I became interested in what limits exercise in respiratory disease, and then I became interested as well, because I'm sort of interested in the respiratory and the cardiovascular system, so the heart and the lungs, how what goes on in the lungs may affect our hearts as well, because unfortunately or fortunately they're connected, so you can't really study one without the other. And then I was interested in how what we had learned for athletes, how the exercise that athletes do might be able to be used in athletic populations. populations. Now, I'm not talking about you guys running marathons if you have a respiratory condition, but just understanding the processes that we use with athletes, how we might use that with the general population or people with respiratory conditions. So as Dr. Rolf said, if you have COPD, as you exercise, the big problem is you can't breathe out. You just can't get that air out quick enough. So often your brain tells you you've got to breathe in before you've fully emptied out. And you get this slow gas trapping, which sort of fills your lungs up. So while you're exercising, if you exercise a little bit too hard and your ventilation gets a little bit, or the demand to breathe gets a little bit high, you often get this gas trapping that can make you very, very short of breath. Now that gas trapping is related to the amount of ventilation you need, but it's also your brain telling you that there's a bit of a mismatch between how much ventilation your body can generate and the work that you're doing to try and achieve it. So one of the main limitations for people with COPD is that they have this shortness of breath or dyspnea, which is very, very uncomfortable and very, very unpleasant and causes the anxiety that we've heard of from Shelly. And I'm sure some of you have experienced it before. It's a very unpleasant feeling. And it's this, a lot of people describe it as the feeling of not being able to breathe in, even though the problem is getting the air out. So it's this feeling of inspiratory effort and inspiratory problems. Now, we're also interested, I'm going to speak just a little bit on the heart side. When you've got these nice or full lungs, which you don't necessarily want, it creates a couple of things which also influence the heart. As we breathe in normally, to get air into the lungs, our muscles widen our chest cavity and produce a negative pressure within the chest cavity. Now that then it creates a gradient between the atmosphere and the lungs, so that's what brings air into the lungs. So we need that negative pressure. But if you've got big, full lungs, often that creates a bigger negative pressure. And that negative pressure, or additional negative pressure, can put a load on the heart. So the heart has to work a little bit harder to actually get blood out of it. Additionally, something we're learning more about, it was first sort of shown about 50 years ago, but now there's been a lot of studies that have been done just recently that show that if your lungs are a little bit bigger and they've got this trapped gas in it, it can actually also squeeze the heart a little bit. That doesn't mean you have heart disease or heart problems, but your lung is cushioning, if you like, the heart. And people with COPD who've got expanded lungs often have smaller hearts because of the cushioning of the lung. And as you exercise and you have these swings in negative pressure and you have this cushioning, you may not get as much blood out of the heart as someone who doesn't have this condition. So unfortunately, there's a sort of double whammy. You've got the lung condition that's causing the shortness of breath, but the lung condition may also be affecting the heart. We don't know how that affects exercise capacity or exercise tolerance per se, not yet anyway, really clearly, but there's good evidence that it probably does. So we were interested many years ago now to actually try and do something about this. Now, we know exercise works. I'd like to take Shelly with me every time I go and talk. That's about as powerful message as you're ever going to get. You could read all the literature in the world and not hear it as clearly as what Shelly has just told us. But we know exercise works for patients with COPD. It's part of the standard of care for patients. You should all be exercising if you have COPD or if you know someone with COPD. And pulmonary rehabilitation is a very structured way of doing it. And we know a lot about pulmonary rehabilitation. We know that it improves exercise tolerance. We know it reduces symptoms. We know it improves health-related quality of life. But it has numerous other effects. It reduces the anxiety and depression. It may make you sleep better. It may make you clear the mucus out of your lungs better. But it also stops people going to the hospital more regularly and having worsening of their symptoms over a year. So it has a huge amount of benefits. So we know it works. The sad thing about exercise, though, is it can't reverse the lung damage that has actually occurred. It's not that good. And to this minute, there's still nothing that is really that good to reverse that lung damage. So what we needed to do, or what we wanted to understand, is if the lungs are limiting, what can we do about it? We can't necessarily change the lungs, but let's take some of the stress off the lungs, right? And that's something we can do. So we know exercise can improve our muscle strength, it can improve our muscle quality. When our muscles work and they're deconditioned, they demand a lot of oxygen, which that comes from you breathing a lot, okay? But they also produce a lot of CO2, that comes from metabolism. So that CO2 drives the breathing that you actually produce and makes you that shorter breath because you've got to breathe hard. So what we want to do is try and change the breathing, or try and change these adverse patterns to try and improve your shortness of breath and get you to exercise more or feel more comfortable exercising. So what we did, one of our first studies that we did a long time ago now, is we used two different gas mixtures. We used oxygen, and this is not in people with COPD who needed oxygen, but oxygen has a really interesting side effect. If you give it to a patient with respiratory disease, what it can do is it can slow your breathing down. Now, if you slow your breathing down, that problem about getting air out because you don't have enough time to get it out, it gives you more time to get it out. So if we were exercising people on air at around 60 to 70% of what they could do naturally, we had patients go on average for about 9 minutes. If we give them oxygen, now they didn't have oxygen problems, they didn't need the oxygen, but if we slowed down their breathing, they went about twice as long. They went about 16 to 18 minutes. Now, another thing we did, which we thought was quite interesting, is we thought, well, if oxygen works, let's use a different gas mixture. Let's use helium oxygen. Helium is a very light gas. It moves through the airways very, very easily. We know it because it makes our voice squeaky and it makes balloons fly. But it's a less dense gas and it moves through the airways of the lung very, very easily. Joshua would know a lot more about that than I do, but it allows, because of the density, it allows you to move through the lung. And this actually pushes the air out very, very easily and allows you to breathe and reduces that trapped gas. So we combined that with oxygen and people went 3 times as long. So instead of going 18 minutes on oxygen, they went 26 minutes on the helium oxygen mixture. So now we can have patients go a lot longer. So that was one way. We could take the stress off the lung. A project we're doing now, which I'm very excited about, is we're doing something with resistance training. And resistance training is just strength training. And we think about it as strengthening the muscles of the body. And it's not now necessarily weightlifting, but we thought, well, if we could condition the legs, which are the big muscles which produce those byproducts and make us breathe a lot, maybe we could reduce the ventilation that people are producing. So I've got a student at the minute who's doing a very nice study where she's strengthening just the legs, nothing else within the body, to see if we can change the quality of the muscles within the legs and change the breathing. Well, she's had an amazing effect in the first few patients we've had through. That training of the skeletal muscle really slows down the ventilation because we've got receptors in the muscle when we're producing these byproducts that drive our ventilation. And what she's shown is it reduces the amount of gas trapping you get, and people feel a lot less short of breath. And when we make them exercise or walk, they can go a lot longer. So these are some of the studies that we're currently doing, and we feel that while exercise is very, very important, there's certainly ways, and what researchers like I can do is now try and find ways to make exercise or think about the problems within the lung and try and come up with ways to exercise that may improve the lung function independent of changing your lungs, try and change those symptoms, and try and improve the lives that you actually have when you're living with a chronic condition. Thank you.
Thanks, Neil. Please remember, let's note down some questions as our speakers are going along. Our final speaker before the break is Dr. Pat Camp, who I will pass over to now.
Thank you. Thank you for the invitation. And I'm going to end the session today with talking a little bit more about some of the practical nature of pulmonary rehab, so you might have an understanding whether or not you've been there before, or whether you're interested in going, or you know someone who you think might benefit based on what you've heard today. So it's absolutely true. Pulmonary rehab is probably one of the best treatments we can offer people that have chronic lung disease, especially COPD. The research is very rich. It's really strong. There's actually been some indication that certain types of studies we don't even need to do anymore because the results are in, and that this is an intervention that works. The Canadian Thoracic Society says after you have all of the medical management, you're on the right kind of inhalers, you're on oxygen if you need it, the next thing that has to happen is, besides quitting smoking, is going to pulmonary rehab. So as Neil said, it improves your shortness of breath, it improves your exercise tolerance, it allows you to do the activities of daily living that you need to do much easier. It improves your mood, it helps you sleep better. It seems really to be sort of ticking all of the boxes in terms of the kind of improvements that you can have. So what is it? We've talked about it, but what does it actually look like? Well, these are group exercise and education programs. They're usually run groups of about 10 to 12 people, sometimes a little more, sometimes a little less. Not everybody is going to have the same kind of lung condition, but most of the people that go to pulmonary rehab have COPD. So what happens when you're there? Well, typically you'll get a referral from your physician or your respirologist. Some programs allow you to self-refer, but most people are getting a referral from their doctor. And the first thing that happens is that you'll get a call from the program to usually come in for an assessment. They want to know more about you. They've got usually information about how your lungs work, they have a medical history, but they really want to understand why you're in the program, what you like to get out of it, what are the goals that you may have, maybe what are the concerns that you have. A lot of people will say to me, I have a breathing problem, I can't really do much. I'm really uncomfortable about being asked to go into a program where I'm expected to be active. And so that is the key part of that initial session, is where we talk about what the program offers and we figure out what you could get out of it. What are your goals? They're not going to be the same as another person that's in the program. Now, a key part, the most important part of a rehab program is the exercise. And so the next thing that the program will probably have you do is some kind of an exercise test. It might be a walking test. It might be a test on a bicycle. It might be doing how many times you can go up and down a few stairs or get in and out of a chair, or how strong you are in terms of your muscles. The idea of each person doing a test is that they want to create a program that's individualized for you. So you might be quite fit, and so your program is going to look quite different than maybe someone who isn't so much. So the idea is to start the program at a place that you can do comfortably, and then as time goes on, we're going to make it a little harder. Your body adapts, you get more confident, you learn how to handle your breathing, because the shortness of breath can be quite a challenge to begin with. You get more skills in handling that. Then you start the program with a lot of other people that some might be at your level and some might be at a little bit different level. Another important part of the program is the education and the skills that we can help you with in terms of managing your lung condition. And I don't think people really appreciate how complex it is to handle the different inhalers that you may be using. Everyone seems to have like 4 or 5 different kinds of inhalers, and a lot of them have completely different skills. Some you have to breathe in fast, some you have to breathe in slow. Some you have to turn it this way, some you have to turn it this way. You put a little pill here. It's really quite complicated. And the research shows that most people only get much less than about 25% of the drug in those inhalers, just because they're not really using those inhalers properly. So we can help with that. So the programs last about 6 to 8 weeks, go 2 to 3 times a week. Some programs will then continuing on with some kind of a maintenance program that might happen in a community center or with their program, or you may be given some kind of an exercise program for you to do, to continue on after you leave. So the programs are quite a few of them in the Ontario Health Authority, and a lot of them have strong research involvement as well. And I've been fortunate to be involved with a number of different studies with some of the different interior health programs. One study that we're looking at is what kinds of programs should we be offering to people that live in more remote or rural communities. And that came from research that happened here, where we were finding that people were saying, I have a huge acreage, and then you come and you want me to ride a bike for 5 minutes. How is this remotely relevant to my lifestyle? So we realized we needed to learn more about what it was like to have a chronic lung disease when you live in a community where the properties are large, or where you have issues with air quality, especially with some of the smoke that's been happening with the wildfires. So that's some of the research that we're doing. Another study that we're doing is looking more at telehealth. So there are only about enough programs to be able to support about 5% of people that have chronic lung disease in Canada. That's nowhere near enough, of course. So can we use teletechnology, like different kinds of wearables, Fitbits everyone has probably heard of? Can we use our our smartphones to be able to deliver rehab? What if you were able to talk to a healthcare professional and talk to them about your exercise program, even if you lived in a community that you couldn't get to a rehab program that easily? So that's some of the research that we're doing as well. Another area of research that I'm really interested in is how can we have people, when they come into the hospital with an acute exacerbation, with a flare-up of their lung disease, how can we have them go home a little bit more active? There is this real issue in hospitals when you go into the hospital that everyone just sort of convalesces and is flat on their back for 5 or 6 days while they're getting over their lung problem. And we know that you lose so much of your muscle function if you spend too much time just lying in bed. So some of the research that we're interested in is if you happen to go into the hospital with a breathing problem, with a lung attack, how can we keep you as mobile as possible so that you don't feel like you're really just going home and you're completely debilitated? Recognizing, of course, that you do have problems with your breathing. So a lot of the research around pulmonary rehab, around the delivery of it, is looking at ways to increase the access for people, looking at making sure that what we're teaching people is actually meeting their needs, making sure that the exercise, there's always opportunities to fine-tune that, and Neil has mentioned that they're looking at more creative ways to deliver different kinds of exercise programs, and also thinking about providing rehab for people that conditions with other than COPD. What about rehab if you have severe asthma or pulmonary fibrosis? How can we make sure that the programs are meeting the needs of people that have those conditions? Now, if you're interested in a rehab program here in Interior Health, there's a few places to look. You can go onto the Interior Health websites, and they actually, if you just search for pulmonary rehab, you will get a list of the different pulmonary rehab programs and the pulmonary education programs that are available. And you can call the local hospital. There's an excellent program here in Kelowna. There's one in Vernon, Penticton. It's a number of places. Actually, Interior Health Authority is one of the best served in terms of pulmonary rehab because they invested money in these programs about 5 years ago. And although some programs haven't stayed exactly the same, there is still quite a bit available for people that have these conditions. There's Facebook groups available. There's BC Lung has supports available. So there's a fair bit of information. Calling your hospital, the respiratory therapy or physiotherapy departments, or asking your respirologist or family physician, well, you can find out more about programs in this community. Thank you.
Thank you, Pat. So that concludes the first part of this evening's activities. Thank you, all of the speakers. Great job. Now it's going to be kind of over to everyone else in the room, but we're going to have a short break. There's some refreshments that we should all enjoy at the back of the room. But please come back in probably 10 or 15 minutes. We'll reconvene, and then we'll have an open floor discussion. So any questions you have or any comments you'd like to make, we'd like for you to share them with us. Towards the end of that, I'll then invite each of the speakers just to recap and give us a final few comments before we'll finish at 7 o'clock. So enjoy the refreshments and see you back in 10 or 15 minutes. Thank you very much. Okay. Hopefully we're all refreshed. Now to the fun part of the evening, I think, for the panel members, because they don't know what questions are coming. So I think that will be really interesting. Now we have a roving mic. Joan's got the microphone. So if we can, I'll ask people for questions, and then if you'd like to just direct the question you have to a specific panel member, or if it's an open question, please say so. So please, first question.
All right. Hello. I think this question is for Dr. Rolf. I was quite shocked with the number that you threw out at the beginning and saying 21% of people don't survive after a year of hospitalization. I'm wondering, is there a thought or two that you know that are somewhat a good opinion of what might have that number increase?
That particular number comes from sort of morbidity, mortality stats over the years. Basically, it's one of the little stats that supports the use of antibiotics and an action plan in treating obstructive lung disease. There was a physician in Winnipeg who about 1986 or so did a study with people with obstructive lung disease. And I know I'm not answering your question directly. And he took individuals with obstructive lung disease who had an increase in cough or sputum, change in color of sputum, and randomized them to either regular therapy at that time or an addition of an antibiotic, which was tetracycline, ampicillin, or erythromycin. And he showed a dramatic decrease in hospitalization and admission. What we do know is that if someone does end up in hospital with an exacerbation of their lung disease, that you follow a large number of those individuals, that there is a mortality rate of about 23%. And that's all comers, whether it's mild, moderate, or severe. Now, having said that, you say, well, why would that be? And people with obstructive lung disease have usually more than one underlying medical condition, whether that's heart disease, whether it's diabetes, whatever. And if you think about it, if I do have heart disease and I've got obstructive lung disease and I'm limited, just as a theory, and I am walking and I get short of breath, and because I'm short of breath, I stop moving. I rest. I get better. Now you turn around and I get sick with a cold, and if I get sick with a cold, I've got increased, I'm going to use the word cardiac output because of the stress of the infection. And let's say now I develop a rigor, the shiver or shake. So now every single muscle in my body is now shivering, and it's doing that to raise my body temperature. And if you have a rigor, whether it's a viral cause or bacterial cause, within about 25 to 40 minutes or 30 minutes, you'll end up with a fever in excess of about 39 degrees. But during that time, it's the same as you're now running a race. Now, if I was running a race with my lung disease and I got short of breath, I stopped. But with the individual who has lung disease and cardiac disease, I can't stop shivering. My cardiac output continues, my stress on the heart continues, and very frequently you'll find people admitted to hospital with, quote, "This is an infectious exacerbation of their obstructive lung disease, and in association they have congestive heart failure and a small heart attack." And so obviously there's a significant stress in the background.
Okay, question over there.
I've got a question for Pat and Neil. So thanks for coming to Kelowna, Pat. You picked the warmest day of the year so far. So first question is about balance and its role in pulmonary rehab. I noticed that you were working on a study. I don't know if you published or...
So there has been more awareness that people that have chronic lung disease often have problems with balance. And partly it could be because of their just overall lower fitness and oftentimes weak muscles in their lower legs, that makes it them a little bit unsteady. Add to that shortness of breath and the anxiety that comes with that, and also being on certain types of medications that might make you your heart race a little bit or may make your bones a little bit weaker. There's more and more concern that poor balance, if you have COPD, is something that we really need to address. And so the research on that wasn't great. There really wasn't much in the way of looking at the impact of a balance program as part of a rehab, part of a pulmonary rehab program. So that research is still continuing, but some of the early results suggest that it should be added to pulmonary rehab. It might not be important for every single person to have it, but everyone should probably have their balance assessed. And if you go into a program and you report having a near miss, so maybe you had a trip and you just caught yourself, or maybe you actually had a fall, having balance training as part of your rehab program looks like it's going to be a pretty important part to make sure that you stay safe and healthy in your home.
Thank you very much. So
Ne-
Neil, you were exercising patients with supplemental oxygen. What fraction of oxygen was needed to get improved exercise tolerance?
That's a really good question. It has actually been studied. If you're non-hypoxemic, so you don't need oxygen, that's obviously different than if you do. If you do, you can sort of obviously titrate it to a certain level to make sure that you cure or alleviate the level of deoxygenation or the poor oxygenation that you have. For an exercise benefit, it depends a little bit, but the study has been done where they've looked at 30%, 40%, 50%, and 60%. And to be honest, the balance is somewhere between about 40 and 50%, certainly by our experience and by that study. And what that would do, if you have about 40% O2, is it will slow the ventilation down a little bit, because we're not trying to correct low oxygen levels now. We're trying to sort of suppress the ventilation a little bit. So it's a slightly different reason for using the oxygen. But around 40% seems to work in most patients. In some, you may need to go up to 50, but you don't need to go higher than that.
Okay, next question. Gent in the red, yeah?
Yeah.
Please.
Oh, yeah. Okay. Dr. Rolf, let's say you had mild COPD. Would the reasoning hold up that you would put that person on Spiriva because you may slow the aging process down of the lungs, or is there no evidence to? And if there's no evidence, what would you think about doing that?
Well, that's a little bit of a loaded question. Just in general, let's take a sidestep. I've been doing a lot of sidestepping here. You've got 3 or 4 different classes of medications that have effect on lung function. You've got things called beta-2 agonists, things that are affecting receptors that work a little bit like adrenaline. The beta-2 help relax the airway, they increase the clearance of secretions. A little known side comment is they also help clear lung fluid or lymphatic fluid from the lungs. Things like salbutamol last 4 to 6 hours. There's other ones that last 8 to 12 hours. There's others that are now lasting 24 hours. Another class of medications we call anticholinergics. As you've mentioned, one, the tiotropium, lasts for 24 hours. There's some other ones lasting for 24 hours. Back in the early 80s, we used atropine. And in fact, 40 years ago, they used 3 grains from the bellflower, which is really the Jimson weed, and they smoked it, and that was every 72 hours. Now, if you had too much of it, you had an acute cholinergic crisis and were psychotic, you know, the Mad Hatter. But with the nebulized atropine, that was another agent that we had, and then they evolved this other one called ipratropium, which lasts 4 to 6 hours, and then was sort of in the mid-90s that the tiotropium appeared. The third group was the caffeine-related ones, I'm going to call methylxanthines, the theophylline. We don't see them very often. They work for some people more than others, and they help clear secretions. Getting back to your more direct question, the things like mild or moderate obstructive lung disease, we know that if you use a long-acting anticholinergic agent like tiotropium, that the very first time you use the medication, your airflow may be at this point. However, normally what would have happened with a shorter acting is the airflow would have gone up, and over 4 to 6 hours it would have gone back down to baseline. So the following morning, you'd be back at baseline. With the tiotropium and some of the other ones that are out there, you take the medication, but 24 hours later, although your airflow went up to here, you may be still in that range. So you're starting at a better airflow. And you say, well, what would a better airflow do for me? Well, if you go back to that example of obstructive lung disease, remember I started off by saying, take a deep breath in, let the air out, okay? Where you stop exhaling is where the lungs collapse and the chest wall to expand are balanced. Now with airflow obstruction, you're at a higher level because there's still some air you could get out. Now, if I have a better airflow, I'm going to be more likely to get more air out in that same time period. So I'm going to have less trapped air in the lungs. So now when I take a breath in, I've got more of an inspiratory amount I can get in. And so theoretically, I should be able to do more. So using something like a long-acting anticholinergic does help raise the airflow, get rid of trapped air, and improve your ability to exercise and function. You might ask, well, is it doing anything else? Well, it actually may be at the same time improving the sensation of dyspnea, the Latin term for discomfort or abnormal breathing. I'm going to give you an example of someone that Neil has heard my example of. It was a woman who in her 40s had what's called an alpha-1 antitrypsin deficiency. So she had a congenital or an inherited defect, so that when she had an infection, the white blood cells would release packets of enzymes to dissolve tissue to get at the bacteria, which with smoke or irritants affects the lungs. And this person had end-stage emphysema at the time she was 45 or 47. Following her heart and double lung transplant, for the first month and a half to 2 months, she was limited by the sensation of being out of breath, despite the fact she had basically lungs and heart that had no nerves. They were not attached to her body. She had normal oxygen levels. She had normal carbon dioxide levels. She could do all the predicteds for her exercise testing for someone in that scenario, but was limited by the sensation of being out of breath. Now, what I'm going to get you to do is take that breath in for me and let it out. Okay. Now take that breath in again, let it out. This time keep going. Now that's starting to get uncomfortable. What had happened was, with her previous lungs, because of the emphysema and the lack of elasticity and the airflow obstruction, when she took that deep breath in and let her air out, her balance point was up here. With the new lungs, she would exhale passively, and she'd get to that point, but her new lungs had more elasticity, so they'd pull the ribs down further, which made her uncomfortable. So it wasn't until her ribs reconformed to the new balance point that her sensation of being out of breath went away. So you add something like an anticholinergic that's long-acting, less air trapping, it may help us with that sensation of dyspnea as well.
Thank you. Lady here in the black and white, yes please.
Yeah, this is just for anyone that can answer it. The connection between acid reflux and asthma.
I'm guessing you, Doug.
Reflux and asthma, reflux and bronchiectasis, another condition, or emphysema or pulmonary fibrosis. Depending on who you look at and what you read, it affects as few as about 10 to 15% or as many as 95%. Certainly when I first started practicing here, we really at least I hadn't learned a lot about the effects of reflux and lungs and asthma. But very quickly I discovered through my colleagues locally that it was probably closer to about 90% of my practice had reflux attached to it. Now it's a complicated story, and one can give a whole talk about that, but the blood supply to the esophagus, part of it comes from the blood supply to the airways. And the venous drainage of the esophagus and the airways, there's also some connection. So that there's some interesting sort of interactions. With Veterans Administration studies going back to hundreds of thousands, to 100,000 or 200,000 people, you'll find correlations of coefficient ratios of 1.9 to 2 plus for severe esophagitis and asthma or bronchitis. So there's a whole bunch of other things in there. So reflux is definitely a factor. Another sort of side point, and I could get into more detail on that, but I think that's going into a whole different talk. But about 24% of the population have reflux in average. And if you take people and do a methacholine challenge, which is a test to look at airway hyperreactivity, and you eliminate people who've had recent infections and the other risk factors, it should be about 5% of those people should be reacting. But if you take refluxers, people without asthma, and you give them that breathing test, you can actually see up to about 10 to 15% of those people having a potential reaction to that. If I give you an anecdote, I had a man with cough a number of years ago, and with that cough, worked him up, and we had a test that was a nuclear medicine reflux and aspiration test where they swallowed some orange juice with a radio label, They had them go through a number of different things to try and induce reflux. And then they gave them a glass of juice to take home in a lead-lined cup, and they drank it, came back the following day and had a picture taken. So that morning he came back, his methylcholine test was normal, but he had orange juice in his lung. So we treated his reflux, and his cough went away. About a year and a half later, I saw him again in consult for cough. This time, if he didn't take a single dose of a medicine called cisapride, which went off the market for other reasons a few years back, he had full-blown asthma symptoms. When we repeated everything, he now had a reactive airway and had asthma, and we couldn't document any reflux. So there's a definite link.
Okay, question at the back.
Hello. Todd stole my question about the oxygen percentage, so thanks, Todd. But we're sitting back here kind of having a discussion about the CO2, this is for Neil. The CO2 is what stimulates your breathing, it's your drive to breathe. So you have high CO2, it stimulates your to breathe faster. We just can't figure out how a high oxygen level would lower your respiratory drive. I don't know, we're just trying to figure that out. Can you explain that?
No.
Ain't a healthy person? Well, never mind.
In laters. I've been asked that question a lot, and to be honest, it's never been studied. There's a number of mechanisms by which it could occur, right? I think part of it is that if you're supplying enough O2 delivery to the muscle, the demand is being met, and so you don't rely so much on other sources of metabolism to actually drive anaerobic metabolism to drive the ATP production or the energy production to the muscle itself. So that might be it. Some of these patients, while we say they are non-hypoxemic, so have low oxygen levels, they may still be in a range where this actually affects their peripheral sort of control of breathing, so the receptors within the carotid bodies, which may actually, or do drive ventilation from low oxygen levels, so it may be related to that as well, but there is no evidence of that during exercise. I think it's more related to the changes in metabolism that you get by having a higher O2 content available within the blood going down to the muscle.
Neil, just to follow up, and perhaps Joshua wants to comment, is there a difference in terms of the way in which the gas is going in and out of the tubes and the lungs here, if you've got different gases?
Thank you. I thought I would get away scot-free without having to answer any questions. I like asking questions. I'm a professor. I don't like answering them. So the comment that Neil made during the talk about putting helium into the air, and the comment he made is it's less dense. In fact, that's true. It's less dense. It has less inertia, so it's easy to push around. It's like why pushing a balloon of air is easier than pushing a soccer ball. One is mostly air, it's light. The other one is like leather and plastic and rubber and everything. It's heavier, so it's harder to push. The other factor is when you have helium, it's not only less dense, but it's also less viscous. And so the two effects contribute to making it easier to breathe in. But if you add more oxygen into the air mixture that you're breathing, I don't remember whether oxygen's heavier than nitrogen, whether it gets more like denser or less dense, viscous or less viscous. I'm not sure. Do you know? It gets slightly more dense. So, but probably that would be, so it would be in the opposite direction. But the metabolic factors would compensate for it, it would seem.
Okay, I'm just going to pinch one more question before I go back out to Neil and Pat. Do you think there's any scope of these techniques translating into the rehab community?
Well, is it true that the actual sources of helium are going down, right? So from a practical perspective, it's probably not going to be easy for programs to provide any kind of, novel techniques like that. I think that I think that's not really the intent, though. It's more to have a better understanding, I think, about exercise physiology.
I guess if you could get your patients exercising for longer there, you therefore get a stronger stimulus and get a greater adaptation, potentially.
True, but we'd have to know that that carries over into the other 23 and a half hours of the day. And it might. I mean, there are certainly some studies that are happening with pulmonary fibrosis that Neil and I are part of that are looking at, can we do different things in the rehab program and actually have that impact day-to-day life outside of that? You know, that's sort of balanced with the fact that there's not even enough regular rehab programs to meet 95% of the people that need them. So I don't think that they should be in competition with one another. I think we do need to understand better ways and more efficient ways for people to engage in exercise to sort of maximize their potential. And also keep an eye on the practicality of how can we then deliver this into day-to-day practice, where some programs aren't in hospitals, they're going to be in community centers, they might be in their people's own homes. So sort of trying to balance the implementation and policy side of things with the science side of things is always what we're looking at. I know there's a lady at the front here too that we want to.
I just wanted to ask another one to Neil. Sorry, did you study any oxygen on people with COPD, or has it been studied before to see if it improves exercise tolerance?
Sorry, can you just, if you use oxygen with a COPD patient?
Yeah, has that been studied with COPD?
Yeah, so actually I'm going to combine this answer with a little bit of a response back on the two as well. So from an oxygen perspective, absolutely it's been done. So we've done it and a number of other people have done it in COPD. So if you use a higher oxygen content within your breathing, you can double the amount of exercise that you do. Now, over a rehabilitation program, if you use it within a rehabilitation program, you will get a greater effect. That has been done as well. So in randomized control trials, which is the best evidence we've got, where they split people into two groups blind and they exercise one with and one without the intervention, it works better. That has been done, and it shows that you can get greater improvements. From the helium perspective that we did, we have done the trial with Heliox where you now use that separately as well, and you use it in a randomized control trial, and it does work when you actually take people off it, right? So once you get to the end of the program and you take them off it and you have them on air exercising, they can now do more than the group that didn't get it. So in Calgary, we actually had this in rehabilitation programs. So we had 9 sites for rehabilitation in Calgary when I was there. 2 of them had Heliox available. And so physicians and general practice people could actually refer people to either normal rehabilitation, or if they had someone who had very severe dyspnea and shortness of breath, they could be referred to Heliox. And what I feel about Heliox is that it's not for everybody. You don't need it for everybody. But if you've got very severe shortness of breath, if you're very anxious, if you can't do any exercise at all because the shortness of breath is so bad, you need some help. And it may not be Heliox. I mean, I hear the idea that it is disappearing. I think there's some ways around that. I've got some theories of how you might use it. But I think for some people, if you've got someone who you need to get exercising, you just heard Shelly today give a very powerful talk about how important it is, then it might be a mechanism to get people going. And in that, we did over 200 people in Calgary using this. Unfortunately, the data never got published. This was clinical practice. And in those individuals who did get it, we started using it even just for the first 2 to 3 weeks to get people going, and then we could wean them off it and get them started. Okay, so I do think some of these are important, and if you can't use Heliox, use oxygen, because it starts, and it's really cheap actually. We did the cost analysis of this, and it doesn't cost a lot over a 16-week or 12-week program, which is what we had. It doesn't cost a lot. So I think there's ways around it. It's not for everyone. I hear Pat that it shouldn't take over from rehabilitation, those sort of things, but it might be an option for your hard patients.
Thanks, Neil. We've got a question at the front here.
I feel a little silly. I would like to share. I've been diagnosed 6 years ago with emphysema, and it was very mild because how I was diagnosed is I had a CAT scan for something on my neck, and they called me back because there was something on my lungs. My lungs look like chicken pox, but the actual emphysema is quite mild, and everybody thinks I've got asthma. But what I would like to do is share what I do for it is I breathe the way my mother, who has asthma, breathes. I breathe in, and when I breathe out, I always breathe out twice. Like if I do my Zumba class without doing that, I can't do it. But if I breathe out, every time I breathe in, when I'm doing exercise, I breathe out twice, and I can get through the whole 45 minutes of Zumba without stopping. Another thing I do with the smoke, I always have my puffer because I'm very mild. I always have my puffer, but it's usually I have to buy a new one, it runs out. The only time I've ever needed it is when the smoke's in the air. And when I do have trouble, which happens when the air's bad, I have trouble breathing, what I do is I used to be a trumpet player. I go home, I pull out my trumpet, and I play it for about 20 minutes, and after that 20 minutes, I feel fantastic. My doctor thinks I'm a genius for doing this, but every time my lungs feel sore, I pull out my trumpet. And the unfortunate thing is now I can't do the high notes, so I have to do really awful songs. But that blowing out for that extent, like I sweat, it makes me sweat and everything, but my lungs afterward, I feel like they're young again. So I just want to share that.
There actually is a reason for that. With the emphysema, there's the airflow obstruction. If you remember the little example I gave initially with the air going, right? With your lung disease and the airflow obstruction, you've got a lot of trapped air. Now, if I fill my lungs up really full, I can talk and keep talking and talk 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 and talk. As long as I've got some resistance in it, I keep going and going and going and going. You'll find a lot of the hugely famous wind instrument players had very severe emphysema, like Dizzy Gillespie. That's why they've got between 9 and 12 liters of air trapped in their lungs. That's why they can play those huge long licks. So they're blowing through a fixed resistance, which is keeping those airways open. And as long as you're exhaling, you don't have as much of a sensation of problem. So when you're tight and having problem, I mean, one of the breathing exercises people talk about is blowing through the pursed lips. You're just using your embouchure, and that's why you're feeling better and doing so well.
Thank you.
I had a question.
I use a device too called an Arabic that you get just from the drugstore, and it does the same sort of thing, and you can set it to different resistance. Yeah, and it really helps.
You could use anything to blow on.
Totally.
But making a little bit of music makes it fun.
Yep, totally.
Okay, thank you. Is there a hand up? Someone who's got...
I had a question.
Perfect, thanks.
You said it was 21%. Like I have been on and off with asthma and Ventolin and different puffers, and I didn't get a tube. I got Alva's something. It was expensive, and I said to my doctor, I can't afford that. It was in December, and the bills are high. He didn't offer me a generic one. It was $100, and I went to all my friends that are on puffers. I said, why was I given this when they've got generic ones that are cheaper? And also I wanted to know, with that 21%, like if I'm taking Ventolin, when and how should I take it? And how do I get those tubes? Like, shouldn't I have got those tubes so you don't lose all the stuff going in that your puffers? How do you get those? Shouldn't I have got that from the doctor?
Well, the spacer devices, which were something you plug the inhaler in and fire it, they do help with the droplets and prevent some of the medication land in the back of your throat where it may not do anything. You can certainly ask your pharmacist and ask a family doc about that for as far as the spacer devices. A spacer device, so something you plug. Yeah. There are spacer devices in a number of different. There's an example there, the one there. There's other ones that. Yeah. So what you just put it in, plug it in, and fire it, and then inhale it. Yep. Okay. And sorry, there was another part of. I mean, as far as generics versus brands, some of you'll find generics mostly related to salbutamol, which initially the first one was Ventolin on the market, and there's a whole bunch of other ones out there that are generic. Some work better than others. As far as things like the long-acting inhaled medications, at this point there are not really any generics out there. And part of it is actually the engineering and design of the delivery system for the medication. Like there's things like the tiotropium came out as a powder with a spinhaler thing, and now it's out with a mist. So when you press it, there's a compressed gas that goes out over about a second and a half. Advair is a trade name. There's the meter dose inhalers, the hockey stick shaped devices or discs, where there's a Ziploc baggie that's popped. Those are not generic because of the devices. And so really with a lot of the longer acting medications, there aren't generics, but what I can tell you is when Boehringer Ingelheim came out with a drug called Inspialto, which is a long-acting blue one plus the tiotropium, they priced it the same as the tiotropium by itself, so you got two drugs for the same price of one. Since that's happened, a lot of the other drug companies have come out with similarly priced combination medications. So you just have to talk to your family doctor and try and find out what's the best option for what you need. Salbutamol is an excellent drug, but it lasts is it better than what? Well, Ventolin is a trade name, okay, and it was the first one on the market. We do find some people do better with the Ventolin, some people do worse. It's very independent, but that's something to talk to your family doc about. Okay.
Thank you for your question. Okay, I think we have another question over here.
Yes, Shelly indicated that she could not remember large portions of time when her body was in pulmonary distress. And I was wondering if someone could speak about the cognitive signs of people going into pulmonary distress. So if someone is with them, a partner, a friend, that they can assist in getting that person to timely help.
Pat, Neil. Perhaps you want to tackle it, and also if there's anyone in the room who thinks they may be able to contribute, please raise your hand as well.
That is a very good question, and I don't think even a lot of the training that we get as healthcare professionals really address that. I do agree around this issue about anxiety and shortness of breath, and that it is easy to dismiss someone as just being just as if that's an easy thing, but oh, it's just anxiety. And not really understanding that there can be a body function that contributes to this distress as much as the distress can contribute to the shortness of breath. I think that part of it is a little bit of common sense. I mean, I think that being an advocate for anyone, if you feel like your husband commented and kept fighting, I think that that has to always be, you know, our role, whether we're a family member or a friend. If you feel that it's not right, it's worth pursuing, because just anxiety, it will go away. That in itself is a reasonable thing to address. It shouldn't be something that's just like, if you know that the person has breathing problems and they've done everything that they usually do, they've taken their medication, they've tried their pursed lip breathing, they've gone through their coping steps, if they have an action plan, they've followed those things in the action plan, and if they're still not feeling right, then it is absolutely appropriate to take it to the next level. And it might mean that a friend or a family member has to do more of that pushing. Sometimes we talk to the patients in our program, and Todd may also want to speak to this too, about some of the language that we ask our patients to use when they're talking to their doctor. So we say, you know, if you think you're getting a flare-up, talk about, I'm coughing more than normal. I'm not sleeping the way that I usually am. All of the things I do aren't working, like the pursed lip breathing. I've tried these different things and they're not working, and I need to make sure that I follow the action plan and get more care. And if they're on the phone on a Friday afternoon and the secretary or the, whoever answers the phone says, oh great, we'll get you in on Tuesday, you have to be able to advocate and say, that's not going to work. I have COPD or I have a chronic lung condition. I've done all of these things. I'm having an exacerbation. I need to either see the doctor or I need to know to go to emerge. So I think giving people confidence to advocate for themselves or to have other people fight for them, in a sense, can go a long way. And maybe, Shelly, you would want to speak to that as well.
I now have two, what is it, an oximeter? What's it called? Yeah, I now have an oximeter that I have at home, and if I feel like I'm having an exasperation, I will check my O2 levels to see what my oxygen level is like, and I don't want it to drop below 88%, or I know I'm in big trouble. I try and keep mine in between about 93 and 97, just depending on how healthy I'm feeling, but I do monitor it because as it goes lower, my mind starts to get foggier. I have, real shortness of breath. I become quite lethargic. So to me, it's worth the $35 investment at the drugstore to have that at home just on hand. So if I'm feeling really anxious, I can check.
To answer your question from a different angle, the symptoms could range from someone being very distressed, anxious, leaning forward, short of breath, having to stand up or lean forward and hold things, to the other extreme whereby the carbon dioxide level, which is built up in the lungs and in the blood and circulation, there's a reason they call it carbon dioxide narcosis, is because it puts you to sleep. And so part of the issues, I suspect, if she ended up on a ventilator, was the issue of CO2 being so high and having its impact as far as that. The other reason she may not have remembered that time period, part of it may be the carbon dioxide, part of it may be a bacterial infection of the circulation, and the other one is with the medications we use in the intensive care unit to put you to sleep, the medications that are there, some of them actually help you forget. And so when I was doing ICU, they'd be people I'd be looking after from the time they came in to even 2 or 3 weeks after they got out of the intensive care unit, discharged them, and then 3 weeks later they came back to see me in the office without the foggiest idea who I was, because the effects of the medications were delayed in the system. So it's a combination of things.
It was actually, they asked me before I left the hospital if I wanted to sign a form, a do not resuscitate form, should this happen to me again, or did I want all the help that was available? And I said, no, I want all the help that was available. I didn't suffer at all that I knew. It was hard on my family, but it was a breeze for me.
Okay, question at the front, yeah?
I have a couple of questions. Before I get to them, though, I was diagnosed with severe COPD in 2008. And I saw Dr. Rolf in 2011. He doesn't remember me now because he went away and he told me what was wrong with me and I didn't need to go see him again. But in 2012, I went on to exertion oxygen and I started going to pulmonary rehab at the hospital. And I got to tell everybody here, that is a game changer. You start exercising and it makes a huge difference. In 2012, I could barely walk across the street. And now I'm on full-time oxygen. I can walk around downtown as long as I pace myself, I'm just fine, right? You know, the air does still get trapped in there, but I work out, and I felt that the biggest muscles in your body are the ones that you should work with the hardest, and that's your leg muscles. So that's the ones that I concentrate on the most, because they're the ones that create the most CO2, right? The next one is my chest muscles, so to help with my lungs, right? But my question was, a couple times a year, I read the newspaper, I see on TV, stem cell therapy coming into town. Now, I know, I've gone online and I've done all the research and looked at all the stem cell things. Yes, I totally believe that, right? I totally believe that. That's why I don't go to them, okay? Because I've done my research too, and Google is a terrific tool. But I was just wondering about how you feel about stem cell therapy, and if there's any research being done in that regard. Forget about these guys that are coming to town. I know that they're snake charmers, but that's my question: is there anything coming down the pipe when it comes to stem cell?
What's fascinating is that there's a lot of technological advances that are occurring in the background that we don't hear about in general. Stem cell therapy has done a phenomenal thing when you talk about bone marrow transplants. It's a phenomenal thing for basically certain connective tissue processes that there's really no other alternative, and they've got a number of case reports. There's a condition where you have antibodies destroying elastin, and they've had bone marrow transplants. There have been sort of case reports where I think about 4 years ago, some little girl had severe damage to her airway, and I believe, because I don't know the details on it, I believe that in a lab they used some stem cells on a sort of artificial skeleton of the airway to try to reconstruct some tissue. I have no idea what happened with that. At this point, it doesn't make any effect. In fact, there's been, if you go to the Google again and you look up the stem cells, you'll find panels sitting just like this, talking about stem cell therapy. And those are, there's actually something that was in the Mayo Clinic on one of their sites as well, talking about it. It's not there yet. Will it come down the road? I suspect it might, but when? I have no idea. But at this point, no. I had one person come to see me in the office who in Mexico had paid for stem cells, and they came from a sheep. Okay. Now, here you get, you'd be having it drawn from blood, but it's not quite the right stem cell at this point.
Okay. We're getting very, very close to our 7 o'clock cutoff. So maybe one last question, and then I'm going to ask the panel to summarize very quickly. Okay.
Hi, I'm Eddie from one of the local oxygen suppliers. And
sorry, we can't hear you. Can you get the microphone closer?
Oh, I'm Eddie, one of the local oxygen suppliers, and I just wanted to say thank you for talking. And I have a question for Dr. Blair. So you mentioned that you have a student that's doing some research on exercising the quadricep muscles to take some of the load off that we can experience when we get dyspnea, because of all the work that's related from using muscles and how it can contribute to dyspnea. Do you have any insight on how to exercise the quadriceps for this type of population? Something that's easy, effective, relatively safe. What do you think?
Absolutely. So, I mean, for us, we haven't gone. We've gone a number of different ways around it. I think there's a lot of ways that you can actually train the muscles. Now, this is going to sound somewhat unsafe, but it isn't. We actually want to sort of focus in on those muscles, and we actually do some large muscle group activities. So we've got some patients who have relatively severe lung disease doing squats, and they're doing deadlifts, and they're doing lunges. And so these are big exercises that are done by healthy individuals. However, they're completely modified for individuals' abilities and limitations. So for example, if I took you through sort of a squatting exercise, the first one, which a lot of people do, is out of a chair, right? So you might do it, and if you can't do it from a standing up position, you can use your hands to push up. Right? So that is really working the muscles of the quadriceps, but it's in a safe action. If you were to fall over, it would be back into the chair, because balance is a massive issue. I agree totally with that. Once you've got that strength, the next progression is on to doing without any hands, right? Then we might do it up against a wall, leaning against the wall. We then move on to doing it without any leaning. So now the balance has improved because the muscles are working. I think most of the balance for us actually comes from an unused neuromuscular system. It's really, really interesting. On the first couple of weeks, these individuals have terrible balance problems, and they can't do half of these exercises. But after about 3 to 4 sessions, what you start to see, one of the first things you see is the balance comes very quickly, and I think it's due to adaptations with the ability to recruit muscles in a more coordinated fashion. And they then usually progress quite fast, and we have some of them actually moving on to actually doing sort of weight, you know, as you would in a squat if you were going to the gym and you were going to do that exercise. So you can progress further, and we've done this with pretty much every exercise. What I would say to anyone trying to do this is break the exercise down. If you're working in rehabilitation, or you're working with patients who do this, or you are a patient, just think of a way you can actually exercise those muscles, like getting out of a chair or bending over, and I mean for the deadlift we start in this position and sort of move the hips up, right? And part of it is literally just going through the movement pattern to start before we actually add in any resistance to it. And the resistance can be very light to start, and then you move up. So we're doing a lot of different exercises. We break down a lot of different ones. I think there's pretty much anything that you could do on that level.
Okay, thank you for that. In summary, I'd just like to ask each panel member to just summarize a couple of sentences, anything last that they'd want to say, and perhaps we'll do this in reverse order. Pat, if you could start for us.
So we've talked a lot about exercise and activity, and I would really like you to focus on the positive message that is. We've had a few people that have COPD and that have said how things have changed when they became more active. So even though the condition can be serious, what you do with it, how your body can adapt to it, can be quite remarkable. And so I really encourage you that if you know someone that has a chronic lung disease, or if you have it yourself, and if you haven't explored pulmonary rehab or exercise programs, please do so. It really is a game changer. Thank you.
Neil?
I don't have much to add to that, because I'm in the same place as Pat, really. We're very similar in many ways on our beliefs within exercise. But I honestly think one of the things is that a lot of the time you feel that you can't do it. It's coming over that first hurdle for a lot of people. It's the getting started that is really, really difficult. And actually we're starting a number of studies now which are, what is the minimum amount you have to do to have any effect? And I truly believe that the first step is just getting up and doing something. And even if, on a regular basis, if you could get up out of the chair and do something, that's the place to start. Forget, again, a lot of the messages about exercise. Start by just doing something. But think about the messages about what pulmonary rehabilitation can do and what exercise can do, because slowly then build towards that and start progressing and keep challenging yourself. It's wonderful to hear someone say they couldn't walk across the road, but now they're walking around downtown all the time. That's where you can get. It's not instant. It's a real challenge, but I think you've got to start somewhere, and that first place is just getting up and trying to do whatever you can at this minute in time, and try and do it more and more regularly, and then build up from there.
Josh?
I think my comment is just to point out the relevance of multidisciplinary perspectives, and how groups as similarly different as engineers and clinicians and exercise physiologists, when they put their heads together and address problems, can come up with some very innovative and interesting solutions and generate new answers. And so I think that this is a good example of that interesting perspective.
Thanks, Josh. Shelly?
And mine would be respiratory rehab, without a question. It has saved my life. When I started there, I was very much like that gentleman. I thought I was doing wonderful because I could lift 10 pounds on all the weights when they brought me into the gym to test me. I thought, wow. Well, now most of the weights I can do 50, 60, 70. I had never been on a treadmill. I started off doing maybe 2 and 3 minutes. I do 30 minutes most days now, no problem, and then go on to my weights and that. Julian is a wonder. As the program started to get a little boring and he finds new and great inventive things for us to do. Like it's wonderful. So between respiratory rehab and the Dorchester support group once a month.
Thanks, John. Doug?
Well, first I want to say thank you to the co-panelists, because First off, respiratory rehab had a phenomenal impact on survival, quality of life, decreased incidence of infections. I have to put the plug in that this is the Interior Health in Kelowna has one of the biggest respiratory rehab programs in the province, and they've done a phenomenal job, and that's mostly from the groundwork that people like Todd and Julian et al. Have done. That's not to negate the impact of all the other professionals in those areas. Secondly, there's other medications that have changed what we're able to do and changed their survival. Back in 1979, I still have a chart on my office wall of decline of lung function over time in someone smoking versus non-smoking. And in someone who was smoking, it was about an 80 plus mil per second loss of their flow rate per year. If you quit, it went down to about a 50 to 60 mil per second loss just from the effects of our environment upon us. With the new medications, it's probably down to about, I think I saw one where the loss was in the range of about 28 mils. So the medications and the other things we've done have had a huge impact on things. So medication advances, important, but the most important thing someone can do for lung disease is quit smoking anything. I'm not talking about one particular agent or the other, but quit smoking anything. And getting out and getting active and being involved in the rehab programs, phenomenally important.
Thank you very much. I think a round of applause for our panel members. And you all deserve a round of applause as well. Thank you very much for your contribution. It's been a real pleasure to host this on behalf of UBC, and you've probably noticed I'm not a local boy. I turned up about a year ago, and it's absolutely wonderful to be part of an institution with UBC who embeds their research so closely into the community, and it's so great to see you all here tonight. So thanks again for coming. There's comment sheets on the table, so please leave your comments. We'd love to hear what you think of tonight's session, and hopefully we'll see you all again soon at some other sessions that we're running. Thanks a lot. Cheers.
Thank you. Thank you.
Very nice to meet you.
Yes.